right then, good evening. I hope everybody's well. So I will start talking about the frozen embryo transfer updates and mainly try and focus on the protocols and stuff. So it's not a very long talk. And I think Dr. Goody is going to then add on some of the stuff about how not to do things and what could be the clinical problems, etc. So let's move to slide number 1. So if we look at the UK data, there has been quite a significant change in the 5 years from 2012 to 2017, that almost 100% increase in frozen embryo replacement cycles with 5% drop in fresh embryo transfer. That literally means that almost 1/3 of our cycles across the country now are frozen embryo replacements. So that's a massive change. And it's getting sort of more and more cycles are becoming frozen embryo replacements now. And I think it's probably associated with several things. One of it is that the cryopreservation, vitrification has become excellent. The encouragement to do single embryo transfer is more and more, and even to some degree, legally we have got now targets to meet that we should not be having very many double embryo transfers, and HFEA are organizing, lead organizers and enforcers, I would put it this way, literally force and twist their arms to transfer single embryo transfer, which is great. Cumulative live birth rates have increased, PGTA has increased, so and all kind of leads to reduction in multiple pregnancy rates. So I think that this is a good change, it's a positive change. And also, the other bit we're thinking that it also reduces our risk of ovarian hyperstimulation in fresh cycles. So my question always therefore to everyone is that why not? Why should we not be doing frozen embryo replacement cycle? As far as the long-term data on safety and outlook is concerned, I know that there are questions being raised now and again about large babies, about increased risk of preeclampsia, about potential increase of cancer risks in children born, etc. But these are still all in very earlier stages. We don't yet have the answer for them. Correctly so that yes, we should raise questions about these. But there are pros and cons. Nothing is perfect. And we need to find the right way that works for us and our patients. So if I move to the next slide, which is a very interesting slide, that this is the HFEA data which shows the live birth rate per embryo transfer and multiple pregnancies rates per live birth rate. So the purple line that you see on the top, which is dropping, and that's the multiple pregnancy rates since 1992 down to 2015. So you can see how slowly our multiple pregnancy rates are continuing to drop across all IVF cycles. Then you look at the blue line, which tells you about the live birth rates per frozen embryo, per fresh embryo transfer. And then the bottom one, which is the golden line, which shows the frozen embryo. And now you can see that once we get past 2013, 2014, the live birth rates are pretty much same. If anything, now the FER live birth rates seem to be better than the fresh ones. So I just wanted to show you that what I was talking about on the last talk and even today, it's actually based on evidence. This is something what is actually happening. You also look at this graph, and there are two separate graphs. There's the graph on the top, which shows the number of cycles, and the black line at the top it shows all cycles in UK. Then the blue line is the fresh embryo transfers, and you can see that how they've started to stagnate in numbers and actually starting to drop now, and how the bottom red line, which is a representation of frozen embryos, has started to slowly go up and up and up, and this is probably somewhere here now in 2020. And the bottom one gives you an idea about the overall proportion of fresh versus frozen in the UK over the last 20 years. So interesting HFEA data, and when we keep good records, this is the advantage that a country would have, that you can actually look at what is happening in reality rather just the hearsay. So what is the indication of freezing embryos? Well, you can divide them into two indications. One is an acute indication where you do not start off with an elective freezing, but if your patient have got ovarian hyperstimulation, if you identify submucous fibroids or polyps which were not picked up before, or suddenly you see that there is fluid in the uterine cavity, if you have any complications with the egg collection, major bleedings, into organ injuries where you don't want to transfer the embryos. And the more modern way of thinking of raised progesterone on the day of trigger could also now become an acute indication for freezing embryos. And sometimes it's the social reasons. In our case, when people are traveling from A to B, can't turn up on the day, then you don't want those embryos to go to waste. So this is, in my view, a broad but a very accurate description of what indications are for freezing the embryos where you haven't planned. And what are the planned indications? Planned indications generally would be divided by that if you're planning to do pre-implantation genetic testing for aneuploidy, for monogenic gene disorders, or for chromosomal structural rearrangements, then you need to freeze the embryos to get the results back. If we are planning to do fertility preservation in cancer patients, etc., then again, freezing embryos is an excellent idea. And there are some group of clinicians who have also started to consider freezing embryos in recurrent implantation failure group of patients as well, though in my mind that still is not absolutely crystal clear as an indication, but one can if you really push it. So now let's move on to the various forms of frozen embryo replacement cycles that we do. So the general ones would be the natural cycle FER. That let's start with. What is the advantage of doing natural cycle FER? Well, the advantage is that there is no need for medications. It avoids the adverse effects. Concordance issues are avoided. It also turns out to be a cheaper treatment cycle for patient as compared to the medicated FER cycle. So it has some advantage. And disadvantages with natural cycles, though, often are a little bit more than a medicated cycle, because you will have to do, and you will see in my timeline later on, that you will have to perhaps do more ultrasound scans, more endocrine testing with LH monitoring, etc. You need to ensure that this patient ends up ovulating. And your anovulatory group of people like PCO, etc., which form a large chunk of our patients, are not going to be suitable patients for natural cycle FER. We also, as clinicians, have got no control over the day of transfer because it's dependent on the day of ovulation. So your embryo transfers will fall over the weekend, and it may not work it may not fit into your work schedule or patient's work schedule as well. And about 8 to 15% of started cycles will end up being canceled due to either poor endometrial development associated with no ovulations, or early ovulation, premature LH surgeries, etc. So there is a lot of issue with cancellation with natural cycle FERs, but it's an option, definitely. So what is the other option? The other option is a medicated cycle FER, and advantages are that it could allow you embryo transfer in anovulatory women, so your large chunk of PCO women will be benefited by using the medicated FER. It allows a choice over the day of transfer, which is convenient in case of if your patient had thin endometrium and you wanted to give it a few more days, then you can play around with all of that in a medicated cycle. You can modify the dosages of estrogen. And often as a patient, they feel that they're a bit more in control, and there is a significantly lower cycle cancellation rate as compared to a natural cycle FER. So these are, I think, the big advantages, while disadvantage would be that often there might be a slightly longer course of medications. Medications may have side effects, and it will turn out to be more expensive as soon as you start to use estrogen, progesterone, etc. So what is the third option that we have? And that is a very rarely used option in our clinical practice. I've probably done 1 or 2 or 3 of ovarian stimulation FER cycles. An ovarian stimulation cycle does not mean that you have to use gonadotropins. You can use clomid or letrozole as well. But it allows embryo transfers in an ovulatory women who do not want standard medicated FER. There are patients who will come up and say, I'm not going to take estrogen. I've used letrozole before, clomid before, I'm going to use that. Can you please do an FER using that? So yes, you can. It may involve fewer days of medication than standard medicated FER because you're trying to stimulate the ovaries as well, and you're more likely to get to the point of ovulation up there. And the other advantage is that it relies on the endogenous estradiol, so it may be beneficial in those with absorption issues, which we often see with patches and oral estrogen tablets. So it has got some advantages. And what are the disadvantages? Well, it requires intensive monitoring because you have increased risk of OHSs. As soon as you start to stimulate the ovaries, we're going back to the whole concept of a fresh cycle in some ways. So why do it? Medications would have further side effects, of course. And then if you were going to use stuff like clomiphene, then you have to sometimes put up with the adverse effects on the endometrium. Of course, thank God we have now got letrozole to counteract that. And as soon as you bring in gonadotrophins, they are much more expensive. Premature LH surges will come in. You may then want to bring in antagonists in the cycle. So you can now see how it all starts to become complicated. So this option would be my absolute last option as far as the FER protocols are concerned. So let's look at the timeline or what we will do in a natural cycle. So generally speaking, I tend to do a few more natural cycles than Anil does. And this is what I would generally do, that I would have a baseline scan of the patient between day 1 to 3 to ensure that there are no major cysts or anything seen on the scan, that I'm fine to start off this cycle. Then I would see them back probably around day 8 to 12. And you got to remember that these group of women need to have regular cycles. You can't do this for somebody who has got 40-day cycle or a 22-day cycle. So we're talking about 28, 30-day cycle group of women. So you bring them in to measure a dominant follicle of 14 millimeter and above. You hope that you will achieve that by day 8 to 12. And you also look at the endometrium, where we have discussed before that most people will use 7 millimeter as their cutoff for moving forward. And of course, you need to have your tri-liner pattern, etc. Then once those above targets, then you can proceed to daily or alternate day urine or serum LH monitoring, or ultrasound scan monitoring, or some people tend to combine both. Now, I normally tend to use ultrasound monitoring because I'm not entirely sure if urine monitoring is easy to do. Number one, people don't often interpret the results very accurately. And often the lag timeline means that before the LH surgery happen, maybe it comes up quite late in the urine. And blood tests, you know, again, we know very well that LH has got a pretty short half-life. So I try not to use LH monitoring if I can. And if patients can come in for ultrasound scans, that is much better for me. Sometimes I may combine both, but usually ultrasound based. And once I have got a lead follicle or once I've seen that we are likely to ovulate, or you've gone past 17, 18, 19 millimeter, you've then done a urine LH surge and you get a positive surge. 7 days post positive surge, you do a blastocyst transfer. Or if you are putting back a day 3 embryos, then you do it 5 days post LH surge. And then you do a urine pregnancy test or a serum beta HCG about 10 to 11 days, maximum 12 days post embryo transfer. So that would be your sort of rough timeline. And there will be a few variations on patients base to base, but generally this is what you would use as your guide. Let's look at the one that is a more prevalent one that I would use in clinical practice rather than pure natural cycle. I'm more likely to use a modified natural cycle FER timeline, where we start off again with the same timelines of day 1 to 3 scan, day 8 to 12, look for a dominant follicle above 14, look for your endometrial targets that you want to hit. You can either start LH surge monitoring or ultrasound scan. So until up to here, it almost remains more or less same. Now, once you see a dominant follicle above 17 millimeter and up to 20s, that's the kind of range, I would generally trigger the ovulation using HCG 5000 international units subcutaneously, or you can even go up to 10,000 units if you want, because 10,000 units will have a slightly longer half-life. So it probably will give a possibly better luteal support. And once you have done the trigger, you would do exactly same as what you did in your natural cycle. 7 days after your trigger, you do a blastocyst transfer, or 5 days after the trigger, you do a day 3 embryo transfer, and day 10 to 11, 12, your pregnancy test. So this actually, in my clinical practice, this is the strategy that I apply whenever I go down the route of natural cycle. That HCG allows me to control things a little bit better, and that the days that I end up doing transfer might be a little bit easier for me to do. But as you can see, with any natural cycle, there are limitations with premature LH surges, and they may come and completely destroy your treatment cycle. Is there any other additional monitoring and support that is good enough based on evidence published? Well, there is no data that suggests that there is any benefits in checking for corpus luteum post-trigger or after the surge. And we have talked through our courses in Dubai before, and also online discussions, that a lot of you are very keen to scan patients post-trigger to see whether the follicle has gone or not. But it doesn't seem to give you any additional benefit, except it just makes your life more busy and more complicated. There is also no data to support usage of progesterone as a luteal support in randomized or retrospective studies whenever you go down the route of natural cycle or modified natural cycle. So again, using progesterone for luteal support is not necessary. On the other hand, those of you who love progesterone might say, well, there is no harm if I use progesterone from the day of embryo transfer. What is it going to cause any harm? Will my success rates be poorer? The answer is no. So if you want to use it, you can use progesterone, but I generally don't use it. There is also, same way, HCG probably is the best luteal support, as we have discussed before. And you could use HCG as a luteal supporter instead of progesterone. And again, no scientific data to support for or against, no harm if you use HCG. The only thing I would give you a word of warning when you use HCG as a luteal support on the day of transfer, that if you use a 10,000 international unit HCG, it will hang around in the blood for a good 10, 12 days. So you may end up getting a false positive pregnancy test, raise patients' hopes up, and then they will start bleeding. So just be careful if you were to give any additional luteal support HCG, that you don't have any false positive HCG results. So let's move on to the medicated or HRT frozen cycle timeline. Again, you start from day 1 to 3 of the menstrual cycle, do a baseline ultrasound scan, and then start oral or transdermal estrogen the same time you've done scan. I normally would start, if I'm giving oral estrogen, minimum 4 milligram, maximum 8 milligram, no higher than that. Or if you're using patches, between 50 to 100 microgram every 3rd or 4th day. So you can use either or, doesn't matter. Some people would use pituitary suppression as well, as you know. And Dr. Goody is more keen on medicated HRTs using downregulation with GnRH analogs, while some people also prefer to use OC pills to do the same. So it's your decision. It doesn't matter what you use to suppress pituitary. If you believe that you want to use an antagonist to suppress pituitary, you can do that. You can start your antagonist 0.25 subcutaneously with your estrogen for the first 7 days. And all you're trying to do with pituitary suppression is to ensure that there is no endogenous premature progesterone rise, LH rises, etc., so that your cycle remains pretty uninterrupted. But the third option, you can say, I'm not going to use any pituitary suppression, and I'm going to start like what Dr. Shah does from day 1, day 3 of cycle, and that's perfectly fine too. So I don't think that there is a hard and fast rule which path you take, because the outcomes are not that different, actually, when you look through all the data. So what's the next step then? Well, next step would be, again, to do the same assessment of endometrium, which would be between day 8 to 12 of the cycle. And once your endometrium has hit the criteria or cutoff criteria of 7 millimeter or more in thickness and trilaminar pattern, you can start your progesterone. Again, I'm not going to go into detail about what progesterone should you use and which route is better, because I don't think one route is superior to the other. Yes, there is emerging data to show that perhaps intramuscular progesterone or subcutaneous route seems to give you the best and the most sustained progesterone levels, but feel free, don't be afraid. If you think that vaginal progesterone is your only option available in your clinical practice, then go ahead and use that. So you start your progesterone once your endometrium is ready. There is no fixed number of days how long you have to get to the endometrial preparation. If you are ready within 8 days of estradiol or 10 days, then so be it. And once you started your progesterone, your embryo transfer would be 6 days after progesterone administration. So on the 6th day of progesterone, you transfer a blastocyst, and on the 4th day of progesterone, you transfer day 3 embryo. Some clinics in Europe, and mainly Spanish clinic, who I work with for egg donation treatments often, they often tend to transfer embryos on day 5 of progesterone as well, and there is no clinical significant difference into the outcome. So whether you do 5 or 6, it doesn't seem to matter a lot in straightforward cases. And then you do your HCG or urine or blood HCG day 10 to 11 post-embryo transfer, and continue your luteal support as per local protocol. If you ask me for what I would do, then I generally tend to never use luteal support beyond 6 or 7 weeks, which would be my first pregnancy scan. And if I see a heartbeat, I would generally discontinue all the medications. You can also stop it at the positive pregnancy test, but everyone finds it very difficult to do so in spite of the evidence. Or you could continue up to 12 weeks of your pregnancy. So the decision is yours. Again, there is no data to show one thing is better than the other. So that's your medicated HRT cycle. And then lastly, ovarian stimulation FER cycle timeline. Again, starts off with stimulation, day 1-3 scan, either Clomid, whatever dose you want to use, 50 or 100, letrozole, 2.5 or 5 milligram, and gonadotropin is usually 50 to 75 international units, generally not higher than that. Your 8 to 12 day scan to look at the dominant follicle, endometrial criteria, which is what we have gone through. Then go down the route of ovulation trigger using HCG between 17 to 20 millimeter dominant follicle, and exactly 7 days post-trigger blastocyst transfer, 5 days post-trigger day 3 transfer. So it goes through the same route as what we discussed before. Again, luteal support is not essential. If you want to use progesterone or HCG, feel free, but it's not really necessary. All these protocols that you look at, pregnancy rates are pretty much the same. Doesn't seem to make a huge difference. And therefore, the question I have to ask you is that what is the best protocol? Or you may want to ask that question to me. And my answer to it is that whatever works best for your patients and for your practice should be your best protocol. For me, the best protocol is modified HRT or modified natural cycle. That's the one that I tend to use. HRT gives you more control. Modified natural cycle gives you less control, but similar outcomes. And then, there's all these discussions about whether miscarriage rates are higher in a downregulated cycle or not. I mean, these studies are not robust, and I don't know what to believe, actually. But that's where I'm going to stop, and I'm going to hand over to Dr. Goody, and then I think he's going to present something. Give me 1 second, I'll stop sharing. Fine, Anil, you, and then we can answer questions.
Yeah, so what we'll do, based on Amit's talk, what we'll do is we'll just do a case in which is very commonly seen, and I want you to think slightly laterally when you start looking at frozen embryo replacement cycles. And this is a case which had 3 rounds of embryo transfer done, and she's a lady with polycystic ovaries but with regular cycles, and she had been diagnosed as having a thin endometrium, and eventually came and saw us. So this is a history, and they said in the first cycle, she was downregulated, was given 8 milligram of Proganova, and the maximum endometrium was 6.4 millimeter, and the cycle was cancelled. In the second cycle, you again start with 8 milligram, and what do we normally do? We increase the dose to 12 milligram, and it stopped at 6.5 millimeter, and they transferred the embryos to a negative pregnancy test. In the third cycle, they started on 12 milligram of Proganova, and this was increased to 16 milligram. And then the endometrium, in fact, became thinner at 4.9 millimeter, and the cycle was cancelled. So the woman came and saw me later on. So I said, well, what do? I tell them, come and see me around day 12 or day 13. And that's when, if somebody says, I've got a thin endometrium, and I said, what's the best time to see you? And I said, don't come and see me for a consultation because it doesn't make much sense. What will I do in a consultation? I'll scan you at the wrong time. So I said, let's look at what happens in nature, and let's scan you around day 12, day 13. And then what you do is you keep scanning them to see when ovulation occurs. And so there was no LH surge, blood or urine. And urine is much easier, but you have to remember that urine has a false negative of around 15%. So what is more accurate is, if you're very suspicious, then get a blood LH level done, and we can get a result back in 4 hours. So that makes a huge difference to the way we manage our natural cycles. So eventually ovulation occurred when the follicle size reached 25 millimeter. And then the endometrium was 11 millimeter. So what did that teach us? It taught us that, one, Proganova was not a drug for her. Again, Proganova is not a drug for everyone, and some women will not respond to Proganova. And we don't know why that happens. And some women, as you increase the dose, you in fact start causing downregulation. And that's something which you will see very, very often. So, and that's something we should have to think about. So in this case, now, what I did next was slightly more controlled, because with a completely natural cycle, you have to put in a lot more effort. So the amount of time taken by a specialist to do a completely natural FER is phenomenal. And the amount of time you spend is also huge. So what I did is I used letrozole, and I used letrozole over a prolonged period. And often, why do I use that? I don't use that because letrozole does something different, and letrozole allows you to, is more protective on the endometrium. It can give you a multiple follicular growth without giving a very high estrogen level, but also it is protective on the endometrium. So at the last study which was done, they noticed that letrozole increased integrin levels. It increased the endometrial receptivity genes in 3 cases, in 3 types, compared to clomiphene, and in fact may be beneficial. But adding that gave me some control over how I ran it. On day 14, there was no LH rise. Endometrium was 9.6 millimeter. I triggered ovulation and transferred the embryos. So, and that's how it looked. And I'm not a great follower of Dopplers, but I do Dopplers just to decide on when the trigger should be given. And the endometrium was good, trilamina, she's pregnant, and she had a baby. So what are the learning points here? And the learning points here is that when an endometrium is thin, it may not be thin at all. And you have to start thinking, why is that endometrium thin? And think about how does a woman respond in nature? And that tends to tell us a lot of things. Now, if the endometrium is different in nature, then Proganova is not the drug. And so, if you have patches, then patches seem to be a far better choice, or you can use nature as another choice. And if in nature your endometrium is better, then you're more likely to modify it much better, and you'll be able to get much better success rate in this. So that's one of the learning points which I would suggest is, it tells you much better if whether your endometrium is thin at all. equally, I used to use a lot of down regulator, and I've stopped using it. And there's a reason why I've stopped using that, because of side effects. So I tend to use a medicated cycle. So my general protocol is Proganova 6 milligram to start with, and I usually say, how many days of Proganova do you give? And the evidence is that anything less than 9 days of Proganova may reduce results statistically. So between 9 and the upper limit is not there really, as long as the endometrium remains fine. So I would say minimum 9 days of Proganova. So that's in short about the case, which is quite interesting and which just gives you a slightly better idea. So any questions?
So there was a question which
I think Anil, just allow me to make one or two comments here. Okay. Now, what Amit, no, I just want to differentiate our kind of practice in India compared to what Amit is saying. Amit has put a very simplistic way of preparing endometrium. I think in India, we keep complicating the whole story a bit. Now, we keep doing our E2 levels, we keep doing our progesterone levels. And now, and if, Amit, you're not doing your E2 levels, you're not doing your progesterone levels, still you're able to give a good pregnancy rate. Now, that itself is a very huge take-home point, because we are over-sponsoring, or not sponsoring, censoring, over-censoring the act of frozen embryo transfer by doing so many hormonal investigations. That is one. Secondly, I think all of us need to move towards a modified natural cycle or a natural cycle FET. Because the moment we keep doing program cycle FETs, our complication rate, or as far as the take-home, the baby rates, the perinatal problems are increasing, like preeclampsias, it's quite on a high. So I think, so best answer to that FET, will FET truly improve the perinatal outcome or give you a better live birth rate? Again, your natural cycle has to be specialized. So I think that huge take by yours of doing more of natural cycle and modified natural cycle, I think it makes sense. That's one more thing. And the third is about, there's one question from me about the duration of progesterone. Suppose we have a day 6 blastocyst or day 5 blastocyst. Should we be transferring after 5 days of progesterone, or we will match the blastocyst? So whatever blastocyst you're frozen, you will keep giving 5 days of progesterone and then transferring the blastocyst. Am I right there? Or?
Yeah, you're right. Yeah. So whether you're frozen the blastocyst on day 5 or day 6, that should not matter. So far, as far as the data is concerned.
Yeah. Dave's question of 144 hours frozen blastocyst, I think we will still give 5 days of progesterone and transfer the blastocyst.
Yeah.
And I just want to point out that one more paper, which has been published by, I think, Christopher Brokiel, and wherein they made 2 groups and they transferred cleavage stage embryos. And in one group, they gave 4 days of progesterone, and another group, they gave just 3 days of progesterone. And they found that the pregnancy rates were the same. Only when they gave less days of progesterone, the pregnancy loss, the miscarriage rate was high. The odds ratio was 0.96, with the confidence interval less than 1. It was on one side, so that was quite significant. So then, if we go by this, the fact that the same number of your implantation rate remains the same, with the amount of progesterone going up and down by a day, then that defies the whole concept of ERA. Don't you think so? That we keep minimizing it to that particular hour, the embryo transfer to be done at 120 hours or 144 hours or 12 hours after that. Don't you think it's somewhere it's not syncing with the kind of day-to-day experiences we get in our practice?
Sorry, I missed that. I was replying to somebody's thing on that. Yeah.
Sachin, what was your question again?
No, I said That's okay. From the era, I was asking from the era point of view. We pin down to the number of hours of progesterone,
Yeah.
and then doing an embryo transfer. But don't you think it is not syncing with our day-to-day experience that it wouldn't
Yes.
make much difference?
It doesn't seem to. I mean, apart from the Spanish group who have published excellent outcomes, nobody else has been able to replicate that data as well in their clinical practice. I mean, certainly we haven't been able to either. We do it. I would be wrong to say that I don't do ERA. I do, but that is my absolute, when I don't know what else I can do to get these embryos to implant. So you can argue for and against ERA. I don't know if it's yet a accomplished tool, but maybe it is the right way to think. I agree that we need to, like from our previous talks as well, Sachin, about endometrium and whatever happens at the genetic molecular levels of endometrium is so fascinating, but at the same time, we are pretty clueless that what works and what doesn't work.
And Amit, when you do your natural cycle FETs, how much time do you generally wait after the pickup is over? Generally, you go away with one cycle. You specifically monitor one cycle and then do it in the next cycle. Do you do any homework, more homework than what is necessary?
Are you talking about elective freezing kind of people's replacement cycles?
Yeah. When you've done a vitrification.
I mean, I don't think that medically it matters at all whether you wait for one more cycle or not. I think what I generally would think that most people who have elective freezing often have PCOS and stuff. So we collect the eggs, start the fertilization process, and then put them back onto antagonists to calm the ovaries down a bit for 3 to 5 days. And generally, once they get the period, I will see them once. I will scan them and see what the ovaries are like and do probably an estradiol level to see what it is like. And if I feel that, okay, the estradiol levels are not high now, the ovaries seem to have settled down in 10 days post-egg collection, and they've started to bleed, then I'm very happy to start a replacement cycle. Because originally we had thought about that we give them a month's break or 2 months break and all of that, but that hasn't shown any difference in our practice and also in published data as well.
And Anil, do you downregulate every patient of FET since you're doing a lot of program cycles?
In fact, I've stopped downregulating generally because it gives a lot of side effects. So, and in fact, what I tell patients is that there may be a cancellation rate, and I normally put the cancellation rate per Venova cycle to around 5%. Now, I think somebody here has asked a question, which is a commonest question asked is, do you scan after giving a trigger? I think it's damn dangerous. I think it's chasing the ruptured follicle syndrome. And
I did mention in my talk, Anil, that doing and checking for corpus luteum post trigger is a waste of time. So please don't do that. That it just doesn't matter. It just doesn't matter. And then there is a question about in HRT medicated cycles, does giving high dose of progesterone, 1200 milligram versus 800 versus 600, make any difference before FET? I don't know the answer. It's just that most people will use 400 and 800 maybe, whether you give 1200 and the progesterone coming out of people's ears, but I don't have the answer. Then we have talked that perhaps intramuscular or subcutaneous route seems to be a better alternative to vaginal route, but I don't know. As Sachin has said clearly, 400 will do. I agree.
Yes.
And if it doesn't lead to pregnancy or not good progesterone level, if you've measured it, then think of adding something subcutaneous to it.
Yes, I agree, and I think I think we know a bit more about frozen cycles, and I think the level of serum progesterone seems to be correlated to live birth rates. But it's still early days, and you can't say that it should be done. But it's early days. So there's one paper which has come up in RBM Online 2019 this month, and what it says is if you combine rectal and vaginal, do you get increased progesterone levels? The answer is yes. So we'll do that talk sometime later. I've just written that talk. So what I want to do is I just want to share a slide on how long should estrogen be given, and there was only one study done. So it's a very short presentation. So let me just go through it. And somebody says, can it be given for 21 days? And the answer is yes. So this talk was prolonged estrogen treatment in FER, blastocyst transfer. At what stage does it decrease live birth rate? And what it looked at is, and this was in human reproduction in 2018, observational cohort study. And remember, if human reproduction publishes a cohort study, it needs to be pretty good. From July 2012 to December 2015, less than 42 years, single blastocyst transfer and artificial preparation. And the groups were divided according to duration of estrogen and endometrial preparation, transdermal 0.2 or oral 4 milligram. That's quite often that's all that is required. And day before starting, progesterone measurements were done, and if ET less than 6 millimeter or progesterone greater than 1.5 nanogram, transfer was cancelled. So what does that say? That says that if you have a follicle growing, they would have cancelled it. So there was one group which was less than 21 days of estrogen, group 2, 22 to 28 days, 4 weeks, group 3, 5 weeks, and group 4, 6 weeks of estrogen before a transfer was done. If you look at the results, clinical pregnancy rates, even if you went on for 35 days, remained very much steady. So, and it's probably the only study done. And once you crossed 6 weeks of estrogen, they found that the loss was higher. But otherwise, it seemed to maintain its pregnancy rate. So
completely breaking up what you're saying. Is it me or everyone has got the same?
No, I think everyone else can hear probably.
No, yeah, I can hear you. It kind of keeps, anyway, go ahead.
Yeah, so, and what it shows us is that you can continue estrogen for quite some time before you think that it's going to drop results. So even if you go for 21 days, I don't think it makes any huge difference. And you can see here, 21 days clinical pregnancy rates were brilliant.
Yeah.
So anything else anybody wants to ask?
No, somebody had asked about, do we need to do progesterone level on the day of trigger and also E2 levels? The answer is no, Dr. Vijaya. Less bloods, the better.
So yeah, Indira has asked a question. I've got a very simple way. I don't use dates, day 16, day 17. So I've got this. I've got a mental block with numbers. I think I was so bad in maths. I've got a phenomenal mental block. So what I do is I say Monday trigger, Monday transfer, Tuesday trigger, Tuesday transfer. And it works very clearly. So Monday night I give a trigger, and next day Monday I do a transfer. And that's perfectly.
No, but her question was that if the dominant follicle is on day 18 and she is given a trigger, can the transfer be done as late as day 26 of cycle? The answer is yes. We're talking about 7-day transfer post trigger, so it doesn't matter.
And also in PCOS, sometimes you will end up seeing ovulation happening very late. If you stimulated the ovaries, you may end up seeing ovulation happen day 20, 21. So it doesn't matter, when you give a trigger. Once you give a trigger, then that window of implantation is limited and is varied, which basically means that women have a different implantation window, and ERA may not be the only way of looking at it. Sonali, again, vaginal. So this was a study done in 1992, and that was a study which was done where they took biopsy of the endometrium, and they did serum progesterone levels. So what did cyclologists do? Cyclologists increased endometrium progesterone levels. Evidence is absolutely fantastic, but it did not increase blood progesterone levels. So if you're going to measure blood progesterone levels with vaginal progesterone, we're not entirely certain why women differ in their absorption in serum levels. We don't know. but its endometrial preparation concentration seems to be much better.
There was a question from Dave about would the window of implantation differ in modified natural cycle versus HRT medicated cycle in the same patient? I mean, I don't know how to answer this, because window of implantation can change based on different protocols and even in same patients. So maybe it does, but how will you compare that?
So, let's look at it this way. You use euploid embryos, and then you do an ERA test, and then you do an immune assessment. And if you combine all that, I don't think we cross an 80% live birth rate. So we're missing something. And I don't know the answer. What is the right implantation window? So when we don't know something, we believe what is there.
I think Sachin had mentioned last time that the whole concept of implantation window is flawed as well. That it's nothing like an implantation window. It's a made-up diagnosis. So nature does not have an implantation window which is limited. It's got a pretty wide timeline. So I don't believe that there is a very fixed implantation window as per ERA. So clearly, those who believe in ERA will believe in it, but those who are like me who don't believe in ERA.
I would just like to say one thing about the agonist downregulation. There was one question about using antagonist or agonist. I think I've not seen anybody using antagonist. There could be some papers, but agonist downregulation, I do agree that a lot of people practice it. But I think it should be decided case to case. There are certain cases like endometriosis, small endometriomas, presence of adenomyosis, who definitely require a long down regulation. And before we do an FET, the question next is how much time to down regulate? Maybe a month, 2 months, or 3 months. I think it's not time related. Like what has made you diagnose that adenomyosis? Let's say there's myohyperplasia, or there could be some cystic changes. By giving your down regulation, has it made any change in that in a positive way towards normalcy? Once that change takes place, probably then you can take a call and do FET. Now, is there evidence? Well, no paper published in this, but this is what I would just follow in my practice. And then definitely for that down regulation, giving Zoladex is far superior to than using your leupride depots.
So that Dr. Nweke had asked a question which I had answered before about endometrium 7 millimeter or not, but not trilaminar, what do we do? And I think it's an interesting one because generally speaking, 7 millimeter trilaminar both have the criteria that I look for in my clinical practice. At least a trilaminar to me is a more important thing than just the thickness. Now, if you don't achieve it, then you can continue your programmed HRT cycle for a little bit longer with estrogen. As Anil said, that if you continue for even up to 30 days, it doesn't matter hugely. But my experience tells me that once you don't get good trilaminar endometrium after 3 weeks of being on estrogen, then it's highly unlikely that you will. So those are the group of people I would definitely cancel. I also look at that if the endometrium is thick or was looking trilaminar and has now suddenly started to look more progesterogenic, then I start suspecting that have I missed out on a follicle that was growing in the ovary, and has this patient got a premature LH surge and luteinized endometrium, then again I would cancel. So I think it depends on what you see. And I think, I hope Sachin agrees with that too, that scanning is a very important part. If you rely on somebody else's scan images and results, then you're not going to get a great outcome. You've got to scan your own patients. That's why
you got to scan. You got to scan here.
And that's why a lot of people then start depending on what you're asking about. Should I check estrogen? Should I check progesterone? You have to do that if you have not scanned them. So I think scanning is the key.
I think the question is after how many days of depot we can start endometrial preparation. I think you have to assure that there is a complete down regulation. So You can even do an E2 level or see to it that your endometrium is very thin. She could be amenorrheic, and then you can start, or on the, maybe after giving depot, the cycle starts beyond 15 days, probably you are downregulated her, and then start it off, your preparation. And if you are investigation friendly or curious investigation person, probably do a day 2 E2LH and E2 less than 50 picograms and analyze less than 5. Start it.
I'll give you a very good answer. I think Amit has answered it on estrogen progesterone ratio. I'll give you a very simple question is, use estrogen, get a good endometrium, give 5 days of progesterone, transfer the embryos, and say your prayers. Because I think that simplifies things. And if we, rather than doing multiple tests, which confuses you, a prayer confuses no one because I don't think it reaches anywhere. But I think if it helps you, I do that. I think if I don't understand anything, I pray and I hope for the best. And usually it does, because keep your protocol simple. Don't do any blood tests unless you see a follicle growing or if you see an endometrium change its appearance. And those are indications where I think you need some evidence to suggest why is the endometrium changing, or why, and which basically means there's a small follicle somewhere. And if you want to downregulate, which cases do you downregulate endometriosis? Maybe, again, evidence is very poor. Polycystic ovaries, maybe, again, evidence is, again, we're not certain. But, if you want to downregulate, you can. Whenever you downregulate, side effects are quite drastic. And I've noticed that in my patients. So I usually have started doing a programmed activity. I think prayer, definitely, yes, I agree.
Also, Anil, the estrogen progesterone ratio related question. Sometimes I feel that if you're not doing enough number of frozen cycles, or if you haven't got enough clinical exposure to FER planning, then you start thinking of a lot of theoretical things. Is that right? And I'm not trying to be critical here, but I'm just trying to be very practical. That, looking for blood levels, looking for ratios, these are the things that people often do when they don't have enough clinical patients to see. So just do it. Practical approach is your best approach.
So I'll just show you another slide of saying what is the minimum dose of estrogen. And this is all been presented. So this was a study which they looked at what is the minimum dose of estrogen you should give, and it was less than 7 days. Even then, they had a decent pregnancy rate, even if you give estrogen for less than 8 days. So, so what I do is I tend to go for a minimum 9 days estrogen. But again, that doesn't seem to be very well proved. But you still see a decent pregnancy rate, even if you have got less days of estrogen when the endometrium is ready.
Yeah.
I know. I think that's a good thing of webinar. I think suddenly the world is exploding with webinars, isn't it?
Yeah. I think the next week's topic is very interesting, Anil. The progesterone primed ovarian stimulation.
Yes. So I've done a general review. So I'll do that. Is progesterone as an antagonist? So it's very simple things. Can we do without antagonist, and can we reduce the cost? And we'll talk about that. And I think Sachin wants to do erectile dysfunction. I don't have a clue of what to do there.
What's it? No. I've done a video. I'll send it across to be put on fertility courses. And I'll do one on medical treatment of fibroid in infertility practice.
Okay, that we'll do the week after.
Yeah.
Antagonist downregulation. What is antagonist downregulation?
No, Anil, I've already mentioned it. And as a part of your HRT program cycle, you start your antagonist 0.25 along with your estrogen patches or oral tablets, and continue for 7 days. And basically all you're trying to do is to desensitize pituitary, right? So you don't have a follicle to grow, just like with any IVF cycle. So you can do that if they want to, but I've never used it. But I did mention it because that is one of the things that people do use.
So, if in case you have any cases, I'm quite happy for you all to present a case. Amit had said that some time ago. Just do a PowerPoint presentation, and if you send it to us a bit earlier, we can think. And as I'm getting older, I tend to think a lot more. I can't answer straight away. I think it's a lag period that occurs, but I'm quite happy to sit down and think. And many of you all have attended our teaching and have come to us. And I think you'll know us reasonably well. So what I would suggest is just present your case here. There's no harm in presenting cases, and if we have, all of us learn from each other.
I'm very good at critically evaluating, Anil.
I know that. So that's it.
Okay.
Good. Excellent.
I think next Sunday would be PPOS.
PPOS. Okay, yes. Okay, thank you very much.
Bye-bye.